And his research is mainly focused on improving type 1 diabetes care and reducing complications with special emphasis on fracture prevention. And he has been the principal investigator for many landmark researches and especially artificial pancreas Cambridge. And he's also PI for many NIH funded studies. And he serves as a senior editor for VMC Endocrine Disorders and Endocrine Connections. And he has served various leadership roles according to his capacity. So over to Dr. Bilal Ansar.
All right, thank you. Can you hear me well? Okay, Dr. Pinaki, thanks for the introduction. Can you allow me to share my screen? Thank you. All right, great. I kind of felt a little bit nostalgic seeing a lot of you being mentored by you. So thank you for having me here in this platform. And I hope that your family members are doing well, considering kind of a grave situation in India. And I hope that things gets better over time. And we'll be able to probably meet pretty soon. I won't take much time. I will try to finish it a little bit early because we are running late and I have another meeting that is starting at 9:15. So I will try my best. What I'm going to talk today is about a very brief overview, and I call this like a 30,000 feet aerial view on how diabetes influence the bone health. Very little is known about bone health in diabetes. So again, take my talk as kind of like a gray talk with a pinch of salt. Here are my disclosure, probably not relevant to this talk. So what I will be talking briefly is a fracture risk in diabetes. And when I say diabetes, remember that I'm talking mainly about type 1 diabetes and type 2 diabetes. There are many different kinds of diabetes beyond type 1 and type 2, and we don't know anything about how those different kinds of diabetes might be influencing the bone health. So my talk is very restricted in type 1 and type 2, and my expertise in a type 1, so probably I'm biased towards more about speaking of bone health in type 1 than type 2. Then I will talk briefly about the factors that might be affecting that fracture risk. How should we do a screening of osteoporosis in people with diabetes, both type 1 and type 2 diabetes. And very briefly, I will give you some thought-provoking research ideas. If you are interested in this area, probably you can explore those different areas in this broad disease. So what about the fracture risk in people with type 1 diabetes? And I remember that I was invited to speak at the Endocrine Society meeting in India in 2014, which was in Chandigarh in November. And Dr. Rao was speaking about the bone health in diabetes at the time. And he presented this meta-analysis. At the time, it was not published. And later on, it got published in 2015. But anyway, so we did this meta-analysis that included about 27,000 people with type 1 and about 4 million controls without diabetes. And we looked at the relationship between diabetes and the risk for fractures. And we divided those fractures into 3 categories. One is the major osteoporotic fractures, that's a hip, spine, distal radius, and then hip and spine separately. And the risk for MOF was about 3-fold higher in people with type 1 diabetes compared to controls without diabetes. And the hip fracture was about 4-fold higher, and the spine fracture was about 3-fold higher. A lot of people do ask me, that means that hip fracture is higher in people with diabetes. But to spine fracture, the answer is we don't know. And we know that the spine fractures are mostly asymptomatic. And this is a meta-analysis. This is not like a prospective epidemiology study. And so I think, in my opinion, the spine fractures are not routinely diagnosed because they are asymptomatic. And that's why you see a lesser risk of spine fracture in this meta-analysis. Similar articles have been published. Number of articles suggested the same thing, same message, that the fracture risk in people with type 1 diabetes is higher. Not only that, but the fracture risk also happens at the earlier age in people with type 1 than people without diabetes. And this is, again, nice article by David Weber, a nice guy, He looked at the data from Teen Registry. That's a UK registry. It's called as Health Improvement Network. These small countries have like a really good electronic data, and they capture almost every single life events, medical events in their data. So he looked at about 30,000 individuals with type 1 diabetes, and he matched them by age, sex, and the practice in the UK. And then he selected randomly like about 300,000 controls without diabetes. And then he looked at the fracture risk across the lifespan. So from age 0 to 89 years of age. So you can see here, and I just selected only one figure here because I think that the hip fracture is the most accurate when you are reporting the hip fracture. 99.9%, the patient will end up in an emergency room or hospital when they have a hip fracture. So I just highlighted the hip fracture here. And you can see here that's a dark black line. That's type 1 diabetes, and dashed line, that's control without diabetes. And the fracture risk at any age is higher in people with type 1, but statistically significant difference, particularly in hip fracture, happens somewhere around the age of 50 years in males with type 1 diabetes, and about 40 to 45 years in females with type 1 diabetes. So very remarkable finding that not only that the fracture risk is higher, but it's also earlier. It's happening about 10 to 15 years earlier in individuals living with type 1 diabetes. What about fracture risk in type 2 diabetes? And just this is only a one article that I selected, but again, numerous studies showed the same thing, that the fracture risk is higher in people with type 2 diabetes, but that's slightly lower than what we have reported in type 1 diabetes. So fracture risk is about 1.5 to 2 folds higher in people with type 2 diabetes, and that's despite that they have a higher aerial BMD by the DEXA scan, which I'm going to talk a little bit later. So why people with diabetes have a higher fracture risk? So as a clinician, if you think about a simplistic way of thinking of fracture risk, then you would think about three main factors. Either they have a problem with the bone mineral density, or they have a problem with the bone quality. And the quality, it's a very broad umbrella term where it consists of a structural quality of the bone as well as the tissue material properties of the bone. And I will try to talk a little bit about that later on. And then, of course, even though if everything is normal, but if the patient is keep falling, they're going to fracture, right? So then the third dimension to that fracture risk is falls. And I will highlight the data about each of this briefly. So what about the aerial bone density in people with type 1 diabetes? What are the data? And again, numerous studies, but I'm just highlighting very briefly the work that we have done over past 7 years. We looked at the bone mineral density across the lifespan in people with type 1 diabetes compared to very rigorously matched control. The controls were matched. We divided them into two cohorts, the youth, which is aged less than 20 years, and the adults, which are greater than 20 years. So for a younger, we matched them by age, sex, and pubertal staging. And for adults, we matched them by age, sex, and BMI. And we recruited about 194 patients with type 1 diabetes from 3 ongoing prospective studies, and then 156 really good matched control. Everybody get the DEXA scanner, the same scanner, same technician, everything is the same. And we did not find any clinically meaningful differences between the lumbar spine BMD in patients with type 1 diabetes compared to controls across that kind of age range, different groups. Except that the postmenopausal women with type 1 diabetes had a lower femoral neck BMD and total hip BMD compared to controls. But again, the difference was very modest. We also published a meta-analysis, and this meta-analysis was specifically designed to look at the BMD differences between type 1 and the controls, only the adults with type 1 diabetes, because we wanted to remove the confounders, particularly in a younger group, because they are growing, and it is hard to evaluate the bone cross-sectionally when the kids are growing up. And also the pubertal hormonal changes that are confounding that outcome. So we decided to just be very clear, very clean in this meta-analysis. And again, we did not find any clinically meaningful difference. Now, When I say clinically meaningful, does not mean a statistical significance, right? So meta-analyses are generally large in a sample size. So you find a statistical significance because of a large sample size, but that's not a clinically meaningful difference. So we found that there was a difference of about femoral neck BMD and total hip by 0.05 gram per centimeter square. That was lower in patients with type 1 diabetes compared to control. It was highly statistically significant. But we all know that the statistical significance does not mean clinical significance. And so in my opinion, the BMD was not that different in type 1 compared to control. What about type 2 diabetes? That's a very opposite than type 1 diabetes, is that almost every study, with the exception of very few, found that the BMD, particularly DEXA BMD, is higher in patients with type 2 diabetes. And it's probably because of two things. Number one, the weight, because the weight is one of the factor or stimulus for the bone formation and increase the bone density. And the second is that they have a really long pre-diabetes phase. That's about 8 to 10 years, where they have hyperinsulinemia that leads to more IGF-1 and probably higher bone density. I did not know much about the Indian data, but I invited Dr. Badada to write a review for a current opinion, endocrinology and diabetes, and very interesting data that Dr. Badada wrote in that review. And it's interesting to know that most paper from India found that the BMD is either normal or lower in patients with type 2 diabetes compared to the controls. And that make me think that probably that type 2 diabetes phenotype is very different in India. They are more thin than probably what we see in a Western population. Like, for example, I see a type 1 diabetes, and if someone has a BMI of 35, that's normal for us in US. So that's not the case in India. And so I think that may be one of the reasons that why there is a different findings from an Indian population versus the US population. Okay, now I'm gonna switch the gear and talk about the bone quality, and I'm dividing the bone quality into two different metrics: the structural bone quality and then tissue material properties of the bone. In a structure, there are many ways that you can look at the structure. It's a macro scale and a little bit of a micro scale. And one of the way is the trabecular bone score, which I consider as a macro still. And trabecular bone score, I'm sure every one of you knows about that technology, so I'm not gonna go into the details. The quantitative CT scan and the peripheral quantitative CT scan. The difference between the peripheral is that you're looking at the distal radius and distal tibia, versus in a central QCT, you are looking at the axial skeleton, which is a spine and the hip. So trabecular bone score, I'm gonna just highlight two studies in type 1 diabetes. One was done by our group, another one by another. They found almost the same thing, is that even though, again, I'm gonna remind you guys that the statistical significance does not mean a clinical significance. And we found that the trabecular bone score was lower in patients with type 1 diabetes compared to the controls. And in this study, we recruited 47 postmenopausal women with type 1 diabetes with a mean age of about 60 years. They are living with diabetes for 40 years. So that's pretty long-standing diabetes. Now, statistically, yes, but then think about that. Everyone had a TBS score higher than 1.3. I'm not sure whether you can see my cursor here, but I'm highlighting this portion. And we know that trabecular bone score less than 1.2 is the degraded trabecular bone score clinically, right? So 1.3 or higher, it's essentially normal trabecular bone score in both the groups. So despite that, these postmenopausal women living with diabetes for about 40 years, they did not have a degraded trabecular bone score in our study. So again, remember that even though in our paper says that statistically it was lower, I think clinically it was not meaningful. Similar finding by another group, the trabecular bone score was not different between two groups, and they had a similar score. You can look at that. The mean trabecular bone score was about 1.3 or higher. That means, again, all these patients had a normal trabecular architecture at the spine, at least. And again, TBS is not the best way to look at the trabecular structure, in my opinion. It's a yes, easy tool that can be integrated to the DEXA. It's a good for a clinician, but I think in a research, I'm a very skeptical about using a trabecular bone score for research. It does not really provide us details about the trabecular microarchitecture. Anyway, what about type 2 diabetes and trabecular bone score? Again, number of studies have suggested that trabecular bone score has some value in patients with type 2 diabetes, and it does improve the fracture risk prediction independently of the DEXA BMD. So I think in a type 2 diabetes, the story is different. In type 2 diabetes, I think the trabecular bone score has a clinical implication, has a clinical value, but in type 1 diabetes, in my opinion, trabecular bone score do not have much value. Okay, now going into some kind of a micro scale, particularly micron scale with the extreme CT, that's an HRPQ CT. Again, I'm highlighting one study because this is a really a topic that now if you look, just go into the PubMed and enter the word diabetes and bone, you will find 10,000 articles published in last 15 years. So this is like a rapidly evolving field, but I'm trying to highlight very important studies and give you some brief message. So in this study by Vikram, they looked at 55 adults with type 1 diabetes, 55 control. They were matched, frequency matched. Now remember that one-to-one match is different than a frequency match. Frequency matched by age, sex, and the BMI. And they had a similar aerial BMD between two groups at the lumbar spine, femoral neck, and total hip. But when they looked at the HRPQ CT-based microarchitecture, which is either trabecular or cortical, not a huge difference between two groups. Again, it's because of a small sample size. But when they looked at a separate category that within the type 1 diabetes, those who have a microvascular complication compared to who do not have microvascular complication, in that subgroup, they found that the people with type 1 diabetes having a microvascular complication had lower trabecular volumetric BMD at the distal radius. They had a thinner cortices at the distal radius and increased the cortical porosity. But again, the sample size. So now 55 type 1 diabetes, you are dividing them into two groups. I don't think that the study had a really statistical power to give us an answer whether it's a microvascular complication or something else that might have led to compromised bone quality. But happy to discuss that later on. And what about type 2 diabetes? A really nice article by Sandeep and his group from a Mayo Clinic way back. They looked at 30 postmenopausal women with type 2 diabetes, 30 control groups. And they selected only postmenopausal women because they wanted to be very clear that, okay, it's only one sex, so that we are trying to avoid a lot of biological variation here. And there was no difference in the HRPQ-CT measures at the distal radius and distal tibia between type 2 and control. On the contrary, people with type 2 diabetes had a more trabecular volumetric BMD or increased trabecular volumetric BMD in patients with type 2 diabetes compared to control, which is expected, right? So more weight, longer duration of that kind of a pre-diabetes phase, hyperinsulinemia, all these factors might have led to an increased trabecular volumetric BMD at the distal radius, particularly in type 2 diabetes compared to control. However, very interesting, at the time they did osteoprobe based the BMSI. So I don't know if you guys know about the osteoprobe. So osteoprobe is like a pen that has a small needle, which is in a micron scale. So it's a micron, not like even a millimeter. And you put that on a shin of the tibia, press that, so the needle goes inside the tibia, breaks the bone. Now I'm saying breaks, it's not really break. It's a micro cracks, it's a micro indentation. Unfortunately, we are planning to utilize that in one of our research, but now that osteoprobe company was dinged by the FDA because there was a theoretical risk that small amount of the blood that can go inside that needle and that might cross-contaminate the patient. So there was a safety hazard, and FDA stopped all the research that were used osteoprobe in the US. It's still approved in the Europe right now, I guess. But anyway, so Dr. Khosla looked at the osteoprobe based in vivo micro indentation, and the micro indentation that's called as BMSI, bone material strength index. It was lower in patients with type 2 diabetes compared to the controls, despite they had a higher aerial BMD and they had a more trabecular volumetric BMD in HRPQ-CT. So it's very interesting that despite the dense structure, the material property was compromised in patients with type 2 diabetes. And that's what I think that the field is moving more towards the tissue material property rather than the macro scale or a micro scale, microarchitecture in both type 1 and type 2 diabetes. We also looked at the PQCT. My institution back did not have an extreme HRPQCT. We had an extreme PQCT at the time. Now the difference between that, it's a resolution. So PQCT do not really provide you a detailed microarchitecture of the cortical bone, like for example, cortical porosity. So that's one of the limitation of PQCT. But anyway, we recruited 24 postmenopausal women with type 1 diabetes and 22 controls, postmenopausal women without diabetes. Very stringent criteria. Mean age is 60 years in type 1, 63 in control group. So these people are living with diabetes, and diabetes duration is 42 years, mean diabetes duration. So these people are living with type 1 diabetes for 50 years, nearly, okay, 40 to 50 years. So that's pretty long-standing type 1 diabetes. Their mean A1C was 7.7. So it's not a perfect diabetes control, by the way. And you can look up here. I did not highlight that there was no difference in the bone formation and bone resorption markers between two groups, which is very contradictory to literature, which says that the bone formation and resorptions are lower in patients with type 1. And I will highlight that why there is a discrepancy between some of the studies that we have done versus other studies. And it will be really thought-provoking for many of us, I guess. But anyway, we looked at the distal radius, and in a radius, it's more of an engineering term. We call this is a 3% and this is a 33%. So this is a trabecular bone, and that's, or you can call it ultradistal radius. And this is 33%, that's a more of a cortical side. That's the same for tibia as well. So overall, between two groups, we did not find any difference in microarchitecture, except that the distal radius trabecular volumetric BMD was lower in postmenopausal women with type 1 diabetes compared to controls without diabetes. However, when we divide these patients into two groups, now take that with a pinch of salt because it's a very small sample size, and small sample size without priori hypothesis, it's again not a clinically meaningful data. But we divided that group into two, the adult onset type 1 diabetes and the childhood onset diabetes. Now, many of us think that type 1 diabetes is a childhood disease. We are wrong. 50% of adults are generally diagnosed with type 1 diabetes in their mid 30s to 40s. That's a USA data. So I see a lot of type 1 diabetes. They are diagnosed in the age of 70s and 80s. So that's a wrong concept sometimes, that type 1 is generally a disease of kids. But anyway, so we divided them into two groups, young onset, adult onset. And we just wanted to look at if someone is diagnosed early, and because this is the age that they are accruing their bone. Remember that 90% of the bone is accrues by the age of 20 years. And would that influence the bone structural quality? And the answer that we found is that yes, there was all the parameters were different in young onset versus the adult onset. They had a reduction in the volumetric BMD, more so on a trabecular than the cortical component at both distal radius and tibia. And also very interesting, their endosteal circumference was a similar. So the periosteal circumference, which is outer side, which is the same in both type 1 and control group, but the endosteal circumference was enlarged in type 1, suggestive of a cortical thinness, which is a part of the aging process as well. So I think people with type 1 diabetes, particularly those who have a long-standing diabetes, are prematurely aging because of probably AGE. I'm going to talk about that later on, and that might be a different. But this study is not a definitive study. It just gives you a hypothesis that we need to probably study this factor that might give us some answer. And that lead to our kind of a hypothesis that probably the age of onset of diabetes might affect the different outcomes in this group. What about the tissue material? So the common thing between type 1 and type 2 diabetes is the hyperglycemia. And the hyperglycemia, we know that it's a non-enzymatic glycation of everything, every organ, and collagen is not different. So you have a glycation of the collagen that will reduce the elasticity of collagen. It will become more stiffer and then likely to be more brittle. Number of studies that is including recent publication by Dr. Barada and his group. Congratulations. This was published at the ASBMR as well. And I think Ruben Dhaliwal presented that, and she got a Young Investigator Award at the ASBMR, if I remember correctly. But all this publication gives us a common theme that number one, AGE is being accumulated in the bone tissue in both patients with type 1 and type 2 diabetes, which is, making a sense because these people have a hyperglycemia for a long period of time. And that AGE is correlating with a lot of tissue material properties, particularly fracture toughness, the brittleness, whatever different engineering metrics that you want to talk about. The controversial area in this field is that, number one, there are so many different kind of AGEs in the bone, and which one would be the best? I don't know that part, number one. Number two is there is no good correlation between the bone AGE content and the serum AGE measurement, which is most commonly used like in pentosidine. So we don't know really much about that, the process of the glycation inside the bone and how long it stays there. What kind of a different glycation would have a different kind of effects in tissue material properties again, but I want to probably discuss that in a Q&A rather than highlighting that too much here. And if you are interested in tissue material properties, read more articles by Eve Donnelly. She and Dr. Vasist, they are kind of like really expert in this tissue material property matrix and the collagen matrix and collagen matrix analysis. Okay, just the one brief sentence about the fall risk, just for the sake of the completion of this topic, is we looked at fall risk in people with type 1 diabetes from a T1D exchange. So I was fortunate to serve as a steering committee member for this large group. So what is that T1D exchange? Is a data sharing of 72 clinics across the United States, different part of the geographical, that has a 30,000 population of type 1 diabetes. And we are keeping the record and prospectively following those patients now. And so we sent a really good survey, and Ruben was a part of this study. And I think 476 patients responded to the survey, and 29% of those more than 400 patients with type 1 diabetes reported at least the one fall in the past 12 months. And out of that group, 29%, 10% had actually fracture resulting from a fall. And very interesting finding is that history of a severe hypoglycemia in patients with type 1 diabetes was associated with a 4-fold increase in a risk for a fall in this population. So I think this is a very unique risk factor of fall in patients with both type 1 diabetes and type 2 diabetes, particularly those who are on intensive insulin treatment, because that increases the risk of severe hypoglycemia, and then severe hypoglycemia can lead to falls and fractures. Similar article published by Peter Westergaard and his group, almost the same findings, so I'm not gonna repeat that. It has been documented in both population, type 1 diabetes and type 2 diabetes, but in type 2 diabetes, it's mostly seen in the later age group when they require intensive insulin therapy, and they have a lot of other comorbidities. But the younger group of type 2 diabetes, the fall risk is probably not much known, and it's not that higher than peers without diabetes. Not gonna go into details about this one, but we all know that different medications that we use for management of type 2 diabetes has a different fracture risk. The mechanisms behind that, we don't know. It's whatever we talk about, it's all hypothesis. There are no clear causation or cause and effect relationship between this drug and the fracture risk. It's mostly the association. Like, for example, insulin has been found to be an anabolic in every single animal studies, but then insulin use is associated with the fracture risk, which makes sense because that means the longer this type 2 diabetes that these patients would require insulin over time, they would have multiple comorbidities, and that also increase the risk of severe hypoglycemia, more falls, and they will have more fracture. It does not mean that the insulin per se is causing this fracture. So that situation is similar for all the medication. It's an association. It's not really cause and effect relationship. Even though the SGLT2 inhibitor initially found to have a slightly increased the fracture risk. But if you look at all the cardiovascular clinical trial of SGLT2, and if you pull the fracture data together, again, it's small events, by the way, but there is no increase in a fracture risk with the SGLT2 in type 2 diabetes population. So at least I think those cardiovascular data and analysis of the fracture risk from the cardiovascular data, it's a reassuring for the use of SGLT2 inhibitors in type 2 diabetes. I wouldn't worry too much about the fracture risk with the SGLT2 in type 2, even though there is a theoretical increase in risk. Now I'm going to switch gear a little bit about. So we talked briefly about the fracture risk in diabetes. We know that it's a higher, but then how we should screen these patients for an osteoporosis and what we should do if they have an osteoporosis. Again, this is a study that probably all of you know that the fracture risk by DEXA is not a good matrix of a real fracture risk in patients with both type 1 and type 2 diabetes. DEXA actually underestimates the fracture risk in type 1 diabetes. What about the FRAX? FRAX is a clinical tool. We again all know about the FRAX. And study by Ann Squarts from California, a beautiful study. She recruited 9,000 women and about 7,000 men from a 3 prospective study. And I think you all know about this 3 prospective study. SOF, that's a study of osteoporotic fracture. And number 2 was the Health ABC, that's aging and I think it's a body composition changes, sorry. Yeah. And the Mr. OS, that's a Mr. Osteoporosis study. And here, look at that, the black line, which is a control group that is without diabetes. And then this dashed line here are the people with type 2 diabetes. So at any FRAX level, whether the FRAX is 5%, 10%, 15%, or 20%, the actual fracture of the hip is higher in people with type 2 diabetes, no matter whether you are on insulin or on oral medication. So FRAX predicts the fracture risk, even though it does predict, by the way, it's a linear relationship. So higher the FRAX, more is the fracture risk, but it's a slightly underestimated in patients with type 2 diabetes, particularly, in both groups, patients who are on oral medications or patients are on insulin therapy. And that's true for in both in a man and women with diabetes. What about type 1 diabetes? We just published recently and there was no data around this FRAX. So I will highlight this, what we did. So many of you know that there is a category called as secondary osteoporosis in a FRAX. Now, the secondary osteoporosis does include insulin-dependent diabetes, which is type 1 diabetes. At the time, in those 1980s, they used to call probably as insulin-dependent diabetes. Now, in a FRAX, how that FRAX works is that the calculation for a fracture risk from a secondary osteoporosis is based on the fracture risk from a rheumatoid arthritis. So now remember that the fracture risk in patients who have a rheumatoid arthritis is about 2.5 to 3-fold higher than who do not have rheumatoid arthritis. So when you put a rheumatoid arthritis yes, then your FRAX score goes up. And similarly, when you put the secondary osteoporosis yes, without BMD, remember without BMD, because BMD is a primary variable in a FRAX. When you enter the primary variable, the secondary variables are not included in the calculation. I hope that makes sense. So when you do not select the BMD, let's say, for example, here it's a hypothetical example, 60-year-old female with type 1 diabetes. This is the weight and height, and I'm putting a secondary osteoporosis yes. Without BMD, then you can see that the MOF risk over 10 years is the 19% and hip is about 2%. But when you put the BMD data on, then this secondary goes away. That is not included in this primary calculation. And in fact, actually, it reduces the risk for MOF because the MOF risk is now based on the T-score rather than based on the secondary osteoporosis. So this is the problem with the FRAX. So what we did is we did a study. There is a cacti study at the Barbara Davis Center, which is going on for about 18 years now. So this cacti study, the full form stands for the coronary artery calcium in type 1 diabetes. In 2000 to 2002, so about 20 years back, the young adults with type 1 diabetes and the young adults without diabetes were recruited with the mean age of 30 years, and they are followed for 18 to 20 years now. So what we did in a year 3, when these patients are coming like an annual visits, and annual doesn't mean yearly in this cacti because they are doing it every 3 to 4 years. You don't want to do a lot of CT scan and investigations and high radiation kind of a techniques every year. So we have to be very judicious. Our IRB won't approve that part. So we are calling these participants every 3 to 4 years. So visit number 3 happened somewhere in 2006 and 2008. And we calculated the FRAX without BMD in 2006 and 2008. And then we followed these participants till visit 4, which happened in 2013 to 2017. So we followed these participants for 8 years. We calculated their FRAX at the baseline without BMD, again, remember that word. And then we looked at their fracture that happened between that 8 years of follow-up. And what we found is that very interesting. Number one is that the fracture risk was about 2-fold higher in people with type 1 diabetes. Is it surprising? No, that's the same finding that we published earlier. But if you look at the effect of the FRAX without BMD on a major osteoporotic fracture risk, very interestingly that it is really predicting it very well. So here on this, my right side of the screen, you can see the hazard ratio around 1. Now, you might think that that's a kind of not a strong association. The answer is true, but let's say if your hazard ratio is 4 or 5, that means it's over predicting it. If your hazard ratio is less than 1, that means it's under predicting it. Here, the hazard ratio is very close to 1. That means FRAX without BMD is predicting the fracture risk in patients with type 1 diabetes. A very interesting finding. Again, this is only one study. One study does not mean it's in good evidences, but at least it's a thought-provoking study that we need to probably replicate the findings and probably do some kind of a randomized control trial around this part. But that's just my opinion. There are a number of review articles that has proposed some guidelines or guidance. And I hate to say guidelines, and a lot of people are using that word. Guidelines are generally based on evidences. And we do not have any evidences to form a guideline for a screening and management of our osteoporosis in people with diabetes. So I kind of hesitate to say guidelines. I generally say either kind of a guidance or personal opinion. So a lot of people have come up with different approaches to screen patients with diabetes and probably make some kind of a therapeutic decision. And what they have suggested, again, it's particularly applicable to type 1 and type 2 diabetes than any other diabetes. If they have a fracture, fragility fracture, the answer is yes, go for treatment. If they do not have a fracture, but they are greater than 50 years of age and have some kind of a diabetes-related risk factor, for example, longer duration of diabetes, poor diabetes control, multiple risk factors, including hypoglycemia, fall risk, then in those patients, you want to do the DEXA, look at the T-score, and the T-score, if it's minus 2.0, then treat them. Now, remember that our definition of an osteoporosis in postmenopausal women without diabetes is 2.5 or below. So this group is proposing that if you use the lower T-score category, then actually in other ways that you are over treating this patient, but that's not a wrong strategy, by the way. Or you can just adjust the FRAX either with the rheumatoid arthritis or some other kind of a diabetes specific risk factor. And in type 1 diabetes, my paper suggests that you just select the secondary osteoporosis without DEXA. That might give you some idea about the risk stratification and making some therapeutic decision in patients with diabetes. So my take-home points, again, my presentation is very brief overview because this is a very complex topic and I did not talk about the cellular changes. Happy to take the questions on that part. I did not highlight much about the bone turnover in diabetes. And again, I'm happy to take those questions as well. But the take-home points is that the fracture risk is higher in diabetes, more so in type 1 than type 2 diabetes. DEXA-based BMD is lower or modestly lower in type 1 diabetes, kind of a higher in people with type 2 diabetes. But regardless of diabetes status, type 1 or type 2 status, actually DEXA BMD underestimates the fracture risk in both population. Bone quality is compromised more so in type 1 than type 2 diabetes because type 2 diabetes studies are not consistent about the compromised structural bone quality. But the one thing that all the studies are very consistent about is that the tissue material property is degraded in both type 1 and type 2 diabetes, and mostly because of an advanced glycation and product deposition in the bone. FRAX underestimates the fracture risk in type 2 diabetes, but probably using some kind of a diabetes specific scores or risk, or a FRAX without BMD in type 1 diabetes may provide some better fracture risk assessment. Again, we do not have a good evidences around that part. And main message from my talk is that we don't know anything about how the diabetes influence the bone health. So my talk is more of like a kind of a gray talk where I think there are a lot of areas that we need to explore. And I'm going to spend probably my 2 minutes about some future direction. So those who are interested in research in this area, this is how I think as a clinician and a researcher that I think we can try to look at the effect of diabetes at the various stages of a human development. So it's a busy slide. You don't have to read word by word. But I think we know that now a lot of people with type 2 diabetes and type 1 diabetes, they are living longer. They are now having kids. In the past, the people were probably afraid to have kids, but that's not anymore. So I think it would be very interesting to understand the effect of gestational diabetes or type 1 diabetes during pregnancy, how that kind of a maternal hyperglycemia would influence the fetal development. And when I say fetal development, it is very specific in regards to the bone development rather than the organogenesis, because we know that hyperglycemia has an adverse influence on a fetal outcomes. So I think that's a very interesting area. Again, that's not my area. I have no idea about the pregnancy and diabetes, so I'm not going to probably do much around that part. And then we know that type 1 diabetes and type 2 diabetes are not like something that happens within minutes or hours or weeks. There are stages of diabetes, right? Like our DAISY study from a Barbara Ravi Center that followed patients for now 20, 30 years. We know that genetically predisposable individuals will develop antibodies, and why they develop antibodies at some point of time, we don't know that yet. But from a development of antibodies to development of a dysglycemia or a pre-diabetes takes about between 5 to 10 years. And it also depends on the number of antibodies that you have, 4 versus 1. 4, nearly 100% of patients will develop type 1 diabetes over 10 years, right? So now when you are developing that antibodies, your beta cell mass is reducing over time. When your beta cell mass is reducing, actually, that means that your insulin is reducing, that means your IGF is reducing. And that reduction in the insulin, IGF level, and different hormones may not change the glucose level because they are still able to compensate the glucose, but may have some deleterious effect on a bone. Again, I don't know that part, but this is an area to be studied. And then once the people develop diabetes, then what happens at the early stage versus the late stage of diabetes? And I think that story is slightly different in type 2 diabetes, because we know that in a pre-diabetes phase, you have hyperinsulinemia. So probably what you're going to study of in a pre-diabetes phase in a type 1 diabetes versus type 2 diabetes, it's going to be a totally different pathophysiologically. But this is where I'm focusing right now. So my area is more about once they are in adulthood, then how we can probably detect osteoporosis, how we can probably improve their fracture risk prediction. And probably in future, I'm interested in doing some kind of a randomized control trial to understand what kind of a different therapeutic approach will be helpful to prevent fragility fracture in these people with long-standing diabetes. Now, the complicating piece to this is, one thing is the story always has 2 sides, the good side and the bad side. The good side is that our diabetes care is changing rapidly. Now it's 100th anniversary of insulin discovery by Benting and Best. Everybody knows about that part. Before that part, people hardly survive their 3rd decade of life. Things changed after that, right? And then we focused about 50 years of our research into the purifying insulin, making the insulin better, something that patient can take it easily. And then the DCCT era came where we knew that A1C influenced the diabetes complication risk. We focused a lot on A1C, and now science is ever changing. Okay, doesn't mean that science is wrong. It's if science doesn't change, that means there is a problem there. And now we are moving beyond A1C. We are talking about time in range. We are talking about glycemic variability. Do a lot of research in artificial pancreas space. And we already have 2 devices in the US market. That's a Medtronic 670G. We have Tandem Control IQ. We have an Omnipod 5 coming up. We have a Beta Bionics coming up. So those devices, the automated insulin delivery systems, are making a life of patients so easy. So that's a good part of the story. Now, the complicating piece of that story is that, now let's say, this is a hypothetical, that you are doing a study in 2000, so around that time, and your study is focused about understanding the bone health in people with type 1 diabetes or type 2 diabetes. Actually, you are looking cross-sectionally there, but it tells you the story of last 20, 30 years. how you manage the diabetes of the patients in last 20 to 30 years, right? So let's say if you study the bone here versus here, it will be totally different. And that's why a lot of studies are providing you a contradictory findings that, and now I am studying the bone health in the era of totally different diabetes management. So I think as the science is evolving, our diabetes care is evolving. I think our understanding of how diabetes is going to influence the bone health will change. How the fracture risk will evolve, that will also change. So again, always there is a good and bad side to that. So I feel like it will be very interesting area in future. With that, thank you for your patience listening. You can never do research without somebody who trusts your blind ideas. And I would like to thank the NIH, where I'm getting about close to $1.8 million funding to now. Right now, we are doing a prospective R01 study trying to understand the mechanical change in the bone quality over 3 years of time in patients with type 1 diabetes compared to controls without diabetes. And then other study we are doing is looking at the tissue material property, focusing more on osteocyte density and then relationship between the vasculature and the osteocyte. And that's another $1 million project funded by the NIAMS. So I'm fortunate to have that good funding. My previous work funded by the University of Colorado, DIACOMP, Type 1 Diabetes Exchange, and the Barbara Davis Center Foundation, and CCTSI. And I'm not an expert in everything, so you need a really good team. The team that are very specialized and expert in doing a different research, different things. So thanks to Janet, who is my mentor for the last 7 years, and she's an epidemiologist and very expert in diabetes complication. Prakriti is my DEXA technician. Wendy Court is a bone biologist with the expertise in a sport medicine related to bone changes. Kristen is a great clamp person. So my clamp studies are done by Kristen Nadal and group. Vanessa Shirk is a postdoc fellow. Her expertise in insulin resistance and tissue material changes. These are 2 medical students who work with me and had a really good projects. Dana Carpenter is the mechanical engineer, but focused only on a finite element analysis based strength analysis. And Ginger is more focused on tissue material properties. So they are really great engineers, and they
Dr.
keep
Viral,
telling me that.
Dr. Viral, thank you. I think Dr. Basin is waiting. And
yeah, sure. So thank you for time. Again, I would like to thank all my collaborators and everyone for helping me to develop this area. So thanks, and I'll be happy to take any brief questions if you guys have.
Thank you, Dr. Shah, for an exhaustive and very illuminating presentation, particularly focusing on type 1 diabetes and bone health. Actually, I think we've really run out of time. I had a couple of points, but maybe we can do them offline. Manoj, Dr. Chadha, you have any comments? And I can see Dr.
I think he's left us stunned because there were no questions, fortunately. But yeah, we'd love to interact with Viral sometime offline, as Amrish says. Thanks a lot, Viral.
Thank you.
Yep, sure. And happy to take the questions offline. But I have to take off because I had